Okay guys, let's walk into a very common high-stakes clinical scenario. Okay, you're in the field, okay, outside of the emergency department. You've got a patient in cardiac arrest, most commonly from Pulseless VTach or VFib. You've shocked them once, twice, 3 times, and they're still in VFib. Okay, so the question becomes, what do you do when electricity isn't enough? That is the space that the arrest trial stepped into. Okay? Now guys, I'm Dr. Busti and your host on This Is Why, where we take medical knowledge from what to why so we can meaningfully impact how we take care of patients using the proper context of the evidence. And in this series on landmark clinical trials, we explore practice-changing studies within the context of the broader evidence. Okay? So our goal is to distill down each study to its essentials and place it in the proper context so that we can better understand why we do what we do. Okay? Now based on that, before the arrest trial, we assumed the antiarrhythmics might help in cardiac arrest. But we didn't have good randomized trial data showing that they actually improved patient-oriented outcomes. And that's important because in cardiac arrest, what we care about isn't just rhythm conversion, is it? It's survival, preferably survival resulting in and as a result of good neurologic function. Okay? So the real issue is, does giving a drug or antiarrhythmic like amiodarone actually help patients survive? Or are we just improving short-term physiology? Okay? And so let's dive into the trial design of the arrest trial. Okay? It was a randomized, double-blind, placebo-controlled trial, which is exactly what we all want for a question like this, isn't it? And they looked at adults with out-of-hospital cardiac arrest, and that's very important as you think about the setting. These are patients outside of the hospital, they're in the field, EMS is present, okay, most commonly, right, and they're working in this case or bringing the patient to the emergency department, okay. These patients are in specifically refractory VFib or pulseless VTach, meaning that they've already gone through at least 3 defibrillations, okay? So that's the scenario. Those are the patients, the population that we're dealing with. Now at that point, so they've been receiving CPR, they've been defibrillated, now what are we gonna do? Okay, so patients were randomized to go either receive amiodarone 300 milligrams IV bolus or receive placebo. Okay, what the primary outcome? Okay, it wasn't what we, I think, all desired, which is survival to discharge. It wasn't that. It wasn't to neurologic recovery, right? It was to survival to hospital admission with a pulse. So that means arriving to the hospital on the ambulance, okay, with a pulse. Okay, not perfect, but that's what their endpoint was. Okay, so it's important to stay in the context of the evidence. Here's what the study found. Okay. In the arrest trial, survival to admission was greater with amiodarone, 44% versus the 34% who received placebo. That's an absolute difference of about 10% with a number needed to treat of 10. That means I have to treat 10 patients in cardiac arrest out in the field with amiodarone for one of them to arrive to the hospital alive with a pulse. Okay. Was that relevant? Well, yes, it was statistically significant improvement in short-term survival. But let's take this to an important step further. Okay. We have issues of side effects and then survivability and neurologic function. So let's talk about the safety. Well, all drugs and medications have side effects, don't they? I mean, that's just the reality. And hypotension was higher with amiodarone, 59% versus 48% who received placebo. Not surprising. Also, not surprising, was bradycardia. Okay? Higher with amiodarone at 41% versus 25%. So there are obvious trade-offs. Okay? And importantly, no data showing improved survival to discharge or neurologically intact survival in this trial. That is really relevant, okay? So here's why this study changed practice. Remember, before the ARREST trial, antiarrhythmics were largely more theoretical, okay? After the ARREST trial, we now had randomized evidence that amiodarone improved survival to hospital admission. Okay? That was itself enough to incorporate it into the ACLS algorithm. So this became the standard. After the third shock or defibrillation in refractory VFib or Pulseless VTach, we go ahead and offer or consider amiodarone. But what actually changed? This is where we need to be careful. Okay? Does this trial prove that amiodarone saves lives long term? No, it doesn't. Okay? What did it show? It improves short-term survival to admission, but no proven benefit in meaningful patient-centered or oriented outcomes. Okay? So think about it this way. Are we saving lives, or are we just prolonging the overall resuscitation process? That is the tension, and it's real. Okay? Now, as it relates to the ACLS guidelines, right, we think about kind of what's happening in the current environment. Amiodarone or lidocaine can be used in refractory VFib or Pulseless VTach. That's still relevant. Okay? Now, because over time, we've recognized amiodarone is not uniquely superior. Its benefit is limited to short-term outcomes. Later studies like ALIVE, Rock Alps reinforce similar themes. No long-term survival advantage. So what do we do with this data from the ARREST and these other studies, kind of pulling it all together? Okay? Now consider that patient who's now presenting in front of you. Okay? They've been shocked 3 times. They're still in VFib. Do you give amiodarone? Yes. I mean, the guidelines support it. We have randomized controlled data supporting it. But your mindset should be at some level, right? This may help achieve ROSC or hospital admission, but it does not guarantee meaningful survival to discharge. Okay? And it should never distract from high quality CPR and defibrillation, because the real drivers of survival are still early defibrillation, high quality CPR, and post-arrest care. All right, just like with all studies, there are limitations that we need to understand. All right, let's be intellectually honest. The primary endpoint or outcome is survival to admission, not discharge. Okay? It is what it is. But you can't discharge somebody who doesn't arrive alive. There again is the tension. Okay? And you don't know the future. Small sample size, it was stopped early. Slightly more adverse effects in the amiodarone group, not standardized post-resuscitation care, and no real neurologic outcomes, okay? So the signal we see may not translate to what matters most, okay? So here's the practical way to remember this. ARREST trial showed that amiodarone helps patients make it to the hospital, but not necessarily home. And that distinction matters, so that when you use it appropriately in shock-refractory VFib or Pulseless VTach, but keep your focus on the fundamentals of resuscitation, because at the end of the day, drugs support resuscitation. They do not replace it, okay? That's the trial in context, okay? And this is why, remember guys, our goal is to move beyond what the data shows to understand and why it matters, so that we can apply it effectively in real-world clinical practice. Okay? Now, if you'd like a deeper breakdown, you can download the clinical trial handout outline on this study and the framework and key outcomes. Okay? Just click on the link that we've put in the description of the show or the episode, whether you're on YouTube or our podcast channels, okay? And you can go to thisiswhy.health to access that. It's free, okay? And if you don't have it already, please be sure to consider subscribing to us and keep the learning of the why relevant, okay? Thank you so much for joining us, and we'll see you on the next review of the Landmark Clinical Trials.